With that, I wanted to start the grand rounds, and we start with the land acknowledgement, and I'll read the first part of it. So Ottawa is built on unceded Algonquin and Anishinaabe territory, and the peoples of the Algonquin and Anishinaabe territory have lived on this territory for millennia, and we honor them and this land. This morning I was reading my CBC News app, which I usually do in the morning to see what the heck's going on in the world. And there was a story that caught my eye, and it was this one here. So this is a grooved stone mold made out of granite. And what caught my eye was found in a strawberry field in Saskatchewan. And you can't age this because it's granite, right? It's made from the land, but the estimate of time, it could have been anywhere from 200 to 10,000 years old, and just reminded me of the length of time of human habitation on this continent. And I think that's a good kind of perspective just to keep in mind as to why we do the land acknowledgement. So I thought I would point out what I read this morning and learned what a stone mold was. That groove is where you can tie a rod or a stick or something, and then use this as a hammer. And it was probably used in the process of hunting or of processing a hunted animal. So it was anyway. That's my land acknowledgement for today. Oh, okay. Okay, and so with that, I wanted to introduce our speakers today. So we have 4 speakers, and the title is Words Matter, Exploring the Role of Language in Medicine and Its Impact on Bias and Empathy in Medical Training. I almost said bios because it's a brief bio, and we have Dr. Alexandra Cohen, Sarah Luciw, yeah, sorry, Natalie, Sachrajda, and Jessica Tao. And they are a group of third-year pediatrics residents at CHEO, and they are passionate about promoting patient-centered care and improving patient experience at CHEO. So that was the brief bio for 4 people. And with that, I'll pass it over to them, and we'll get going.
Okay, thank you so much. And thank you all for joining us today. As you said, my name is Natalie. I'm a third-year resident at CHEO in the pediatrics program. And along with my colleagues, Jess, Alex, and Sarah, we're going to be presenting grand rounds today on a topic that we're all quite passionate about, which is the role of language in medicine. So the next slide. So this talk is going to be divided into 2 parts, the first of which will examine the impact of language we use on patients. So reviewing some of the different kinds of language that patients have identified as being problematic, and then exploring how this affects patient care and patient-physician relationships. And while I say physician, because this is what most of the studies are in the literature, this could be applied broadly to all healthcare professionals. And then the second part will explore the impact of language on the creation of bias and erosion in empathy in medical training. So we'll look at what we can do to change that as well, and how we can reduce the use of problematic language in our hospital. So we're going to start with the role of language in medicine. So I think it's important to acknowledge that although this presentation focuses primarily on patients and medical learners, the language that we use affects all healthcare providers. So language in notes and in handover can directly affect physicians' opinions on patients, which can in turn have an impact on how we then treat these patients. And this language also has a large impact on medical learners, who will often adopt the attitudes and beliefs of their preceptors. And then finally, the language we use greatly affects the patient and how they view themselves and their own health as well. So there's 4 different categories of problematic language that have been identified. We're going to explore each of these in more detail in the coming slides, but briefly they include language that labels the patient, language that belittles the patient, language that portrays the patient as passive, and then language which blames the patient. So language that labels the patient primarily consists of medical professionals reducing patients to their diagnosis, their location, their surgery, or their status. And it fails to recognize that the patient is a multidimensional individual, a human being who's currently suffering from an illness, and instead just identifies the patient as the illness itself. So all of these are terms that I came across in one day at CHEO, in patient notes on the wards, and in common areas as well. So you can see most of these are identifying the patient just by their diagnosis, like the bronchiolitic, the API, the asthmatic. But we also have examples of the surgery, so post-op cardiac, and then just their location, which is also quite common at CHEO, like room 6, bed 1. So an example of this, sorry, it should be noted that this language doesn't necessarily have to be medical. So this was quite interesting in the studies. In many of our notes and medical discussions, we apply other labels to the patient, which could then lead to bias and affect our view of the patient and their medical presentation. And interestingly, patients commented that even positive labels, like saying that they were pleasant or delightful, could be detrimental, as the patients didn't feel that it was the physician's place to make that kind of a judgment and remark. So an example of this problem at CHEO would be this child who would, on most of our wards, be called the new leukemic under her medical team. But if we delve deeper into her, this fails to take into account that she's not simply a cancer diagnosis. She loves Dora, she loves chocolate pudding, she bosses her brothers around and the other kids at daycare, she giggles when she hiccups, she has special stuffy for sleeping. And when we reduce patients to their diagnosis, we fail to acknowledge all of these other parts of them. So the second category of language is language that belittles the patient and casts doubt over what they're reporting. Although in medicine, terms like patient claims and patient denies are often used simply to document what a patient has described, when patients read these terms, they report feeling questioned and unheard. And these comments can be easily rectified. For example, patient claims pain is 10 out of 10, becomes patient is experiencing 10 out of 10 pain. And then we also belittle patients when we refer to their medical concerns as complaints, implying that they're being pestilent in their presentation. And although we may not think that we use this language to belittle patients, we don't apply it to ourselves and our colleagues. So I can confidently say in my 3 years at CHEO, I've never once read a note which wrote, physician claimed to hear a systolic murmur. It's always physician heard a systolic murmur. The third category of problematic language, similarly, consists of language which depicts the patient as passive or lacking in independence. So this can be language that emphasizes the physician's position of power over the patient, such as physicians forbidding certain things, or even the language that we use when we say we take a history or we send a patient home. It implies that the fact that the patient is recovered has everything to do with the medical team, nothing to do with the patient themselves. In addition, the language that we use for patients and families can portray them as childlike. For example, when we tell off parents for failing to follow instructions or for failing to notice medical concerns. And this category also comprises language which depicts the patient as misbehaving, which is implying in a way that the patient themselves is to blame for their current medical status. When in reality, next slide, we often don't know what's going on behind closed doors. And by labeling the patient as non-compliant, we fail to delve deeper into the reasons why this is happening. So for example, we explore deeper why a patient may not be taking their medication as prescribed. We can identify other factors that are contributing to the situation, such as cost, inability to attend appointments because of their job, and other factors that are contributing to their situation, and then seek to rectify them. And then along this vein, the final category of language is language that blames the patient. So with advancing medical knowledge, we now know there's so many different factors which come into play regarding how a patient responds to a medication or treatment, most of which are outside the patient's control. And one other piece I want to highlight here is the concept of treatment failure. So I can't count the amount of times I've read or heard a patient failed treatment, which lays blame squarely on the patient, when if we think about it in reality, it's actually the treatment failed the patient. Next slide. As we start to see in the second part of the presentation, the language that we use already has a strong impact on patients. But with the invention of EMRs now and patients having the ability to view their notes, this becomes even more important than ever. So there have been 2 recent studies examining the responses of parents to open notes in both a pediatric CTU environment and then a pediatric ICU environment. And interestingly, many of the negative factors that parents described were specifically centered around language, about feeling judged, feeling misrepresented, and feeling like there were things that were written in the notes which they didn't feel were true. So these are, next slide. These are some specific terms that parents identified as being problematic. So I'm sure you can all appreciate these are terms that we very commonly hear around the hospital, like a frequent flyer in the emergency room, a high-risk individual, patients who are suffering from a disease. And then in terms of phrases to change, managing the patient instead of managing the condition, leaving off the term patient and just calling someone the sickler, compliance, defects or abnormalities in children, and then in terms of genetic counseling as well, instead of reducing the risk of a condition, reducing the chance of a condition, so that we're not implying that it's something negative. So in a review of patient experience of open notes in hospitals, about 10% of patients said they felt offended by the notes they read. And this had a direct impact on their trust in medical professionals and affected their treatment decisions moving forward. And finally, here are some examples of comments from that study. Many of these we've already discussed so far, but I did want to draw your attention to an interesting one, which is that patients report that reading quotation marks makes them feel like the doctor doesn't believe them. And in actual fact, we tend to use quotation marks for medical legal purposes to ensure we're correctly documenting exactly what the patient has expressed. But it's an interesting conundrum that comes up that we may face as the notes become more accessible to patients, that patients view this as skepticism.
Thanks, Natalie. Hi, everyone. I'm Jess, and so now I'll be discussing how language affects patient care and stigmatization in medical training. But here I wanted to highlight a few more examples directly found from social media recently that just highlights these points. So the first post here, after seeing a neurologist, this patient said, "I received the report afterwards," and where she could have said, "Patient reports no new symptoms or relapse," she said, "Patient denies any new symptoms or relapse. Does she think I lied? I'm very confused. The only way to contact is to call and hope I get through." So clearly, this patient is quite distressed with the word denied used, and that she considered calling the physician to clarify. And the second post, which is a response to the first post, I read a note from a PA at my ortho, and she used the word claimed rather than reported or stated, and that pissed me off. I've been a nurse for 36 years, and the only times I've seen claimed or claimed have carried an undertone of skepticism or doubt. Slight tangent, I absolutely hate using the word refused, as in refused meds. I much prefer declined. And so highlighting how words that we have been taught directly or indirectly to use may really be impacting our patient healthcare provider relationships. And so, like Natalie has been talking about, clinical bias is something we encounter every day on our job. But how does language we use in our documentation really contribute to this bias? How does our chart review impact our attitudes towards our patients and our clinical management? And so here is a study published in 2018 from the Journal of General Internal Medicine that explores this. So they had 413 physicians in training. So that included medical students, internal medicine residents, and emerge residents in an urban center in the US, where they were randomized to one of 2 patient vignettes employing stigmatized versus neutral language to describe a hypothetical patient with sickle cell disease. And so here are some excerpts. So Mr. R is a 28-year-old sickle cell patient with chronic left hip osteomyelitis who comes to the ED stating he has 10 out of 10 pain all up in my arms and legs. He is narcotic dependent and in our ED frequently. At home, he reportedly takes Oxycontin and oxycodone. Over the past few days, he says he has taken 2 tabs every 4 to 6 hours. About 3 months ago, patient states that the housing authority moved him to a new neighborhood, and now he has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. So in the more neutral language vignette on the right, so instead of calling him a sickle cell patient, we're calling him a male with sickle cell disease, and saying that he typically requires opioid pain medication instead of calling him a narcotic dependent, for example. On physical exam, he appears to be in distress. He has no fever and his O2 sat is 96% on room air. The rest of the physical exam is normal, although he reports tenderness to palpation of the left hip. 1 hour later, Mr. R is sleeping, but easily rousable and has been cussing at nurse. He refuses to wear his oxygen mask and is insisting his pain is still a 10. His girlfriend is lying on the bed with shoes on and requests a bus token to go home. So in the more neutral language vignette, he is in distress instead of appearing to be, and his physical exam is positive for tenderness to palpation of the left hip instead of him, although reporting it. He seems distressed rather than cussing at the nurse, and that he's not tolerating the oxygen mask rather than refusing it. And his 10 is still 10 out of 10 instead of him insisting that it is. And so after reading these vignettes, residents were then asked to choose what pain management they would prescribe their patient in their vignette. And residents and medical students used the positive attitudes towards sickle cell patients score, or the PASS score, to assess their attitudes towards their hypothetical patient, with a higher score representing a more positive attitude. And so looking at the results here, exposure to the stigmatizing language vignette was associated with significantly more negative attitudes towards the patient and was associated with less aggressive pain management for the patient. They also found that residents' attitude toward the patient was more negative than in medical students, regardless of the study arm, and that there was an inverse correlation between year of training and positive attitude score. And so, really highlighting the importance of reflecting on how, we use our language and the attitudes that we have towards our patients in hospital and in the clinic and how that's perceived by our junior trainees. And so to summarize part 1, language used in medical records can directly influence subsequent physicians in training in terms of both attitudes towards patients and medication prescribing behavior. It propagates bias from one physician or healthcare provider to the other. It further impairs healthcare quality for individual patients. It entrenches healthcare disparities overall for those who are stigmatized, and attitudes towards patients become more negative as trainees progress, and that may be a result of the hidden curriculum and observing negative attitudes and behaviors of our peers.
All right. So moving on, that brings us to part 2. So I'm Alex. Today I'll be speaking about the erosion of empathy amongst healthcare providers. Beware, apathy awaits you. It was my very first month of medical school, and I sat in the lecture hall feeling stunned as the speaker opened up the first slide of her PowerPoint presentation. She continued on with her speech, saying, medical and dental students start out all idealistic and wanting to save the world. But then what happens? You have 2 years until the cynicism sets in. Our speaker didn't come empty-handed. In fact, this was the article that she cited in order to prove her point. It is entitled, "The Devil is in the Third Year, a longitudinal study of erosion of empathy in medical school." I remember feeling so horrified at the idea that a quality that I was so proud to possess had the potential to slip through my fingers. I specifically pursued a career in medicine because of some childhood experiences that I had as a patient, and the last thing that I wanted was to forget about what it was like to be on the other side of the bed. The authors of the study surveyed 456 students at Jefferson Medical College in Philadelphia in both 2002 and 2004. All participants completed a validated scale called the Jefferson Scale of Physician Empathy at 5 different intervals, in the first few weeks of medical school and then again at the end of each year. Analysis of this data revealed a significant decline in mean empathy scores starting in 3rd year. Now, empathy is something that can be difficult to measure, and that in part is because of the fact that it's challenging to define, and no clear consensus currently exists in the literature. There are differing descriptions throughout the published articles, which generally fall into 3 categories. Some researchers have described it as a cognitive attribute, meaning that it predominantly involves understanding another person's concerns. Others have described it as an affective or emotional attribute, which implies that it primarily involves feeling another person's pain and suffering. A third group considers it a combination of the 2. After reviewing several definitions, this was the one that spoke the most to me. Empathy is a predominantly cognitive attribute that involves an understanding of patients' experiences, concerns, and perspectives, combined with the capacity to communicate this understanding. The reason why I preferred this definition is because, first of all, highlighting empathy as a cognitive skill reflects the fact that there's hope for us to be able to instill and teach empathy to others, whereas viewing it as a purely emotional thing makes it more difficult to influence. Furthermore, this definition allows us to better compare and contrast the concept of empathy with the concept of sympathy. Sympathy can be defined as an emotional attribute, which involves the ability to feel a patient's pain and suffering. So while an empathic physician might say, I understand your suffering, a sympathetic physician may say, I feel your suffering. One study identified approximately a 25% overlap between the concepts of empathy and sympathy, which is actually a lower number than I would have expected and further underscores the need to understand the difference between the two. Possibly the easiest way to describe it is this. An abundance of empathy, using our cognitive definition, should always be considered a good thing. According to the literature, it contributes to personal growth of the physician, career satisfaction, and optimal clinical outcomes. On the other hand, an abundance of sympathy can be detrimental to the patient-physician relationship because it risks becoming more about the physician than the patient. It can also impede neutrality when making clinical decisions and can lead to career burnout, compassion fatigue, exhaustion, and vicarious traumatization. Now, you may be thinking to yourself, okay, one study found a drop in the empathy of medical students over time, but was this a fluke? Was this specific to the country or the culture or even just the specific school? Well, after reviewing the rest of the literature, I can tell you this is no fluke, and in fact, the same finding has been identified across many years and many different populations. In 2006, Boston University School of Medicine surveyed 658 medical students and found that empathy was highest in first year and lowest in fourth year. Medical students planning to pursue what they called people-oriented specialties, as opposed to technical specialties, which they defined as radiology or pathology, for example. So the people-oriented ones scored higher in empathy, but they still experienced a decline over time. Similar findings were documented in Iran and Pakistan, while a study in the West Indies documented decreasing empathy in not only medical students, but also in nursing and dental students. So now I'm going to turn the floor over to you for a moment. If you scan the barcode on the screen, it will take you to menti.com, and we'd love to hear a little bit about why you think that empathy might decline over time. All of your responses will be anonymous. I'll wait a couple of moments for you to scan the barcode, and then I'll just change my screen over to the website so we can take a look at your responses. The barcode will be available again when I change my screen over. All right, I'm going to stop share and then reshare in a second. Okay. All right. So I'm definitely seeing a lot of burnout, exhaustion, fatigue, no time to spend in meaningful interaction, culture of medicine, overworked and tired, defense mechanism, desensitized, undervalued, general lack of social skills due to depersonalizations with virtual social reality, combination of home and work balance, stressors, pressure, lack of resources to help patients, technical aspects of medicine. Oh, sorry, I'll go back. I'm just trying to read this one over here. I'll close the survival mechanism. Empathy costs less when the level of responsibility is less. Lack of role modeling. Political environment supports extremism. All right, lots of really interesting comments. Thank you. I think I'll stop share and I'll go back to our PowerPoint and we can talk a little bit about what the literature has to say. Okay. So theories regarding the cause of empathy erosion in the literature include role modeling first and foremost. If your role models are burnt out, exhausted, and have declining empathy, then you're at risk for developing similar cognitive patterns. Another commonly reported concern, as many of you mentioned, is high workload, which in turn leads to other independent causes of reduced empathy, like time pressure, sleep deprivation, a large volume of material to study and learn, and reduced contact with one's support system, including friends and family. Other reported issues include exposure to an intimidating or hostile educational environment, a culture where one might fear making mistakes, and other patient and environmental factors. There's a great quote in the article that I cited earlier on, which states, modern medical education promotes physicians' emotional detachment, effective distance, and clinical neutrality, as emphasized through a focus on the science of medicine and a benign neglect of the art of patient care. Now, while this likely sounds like a pretty dire picture to present, I have thus far focused predominantly on medical students. So what about medical residents? Well, there was a cohort study that was done focusing on medical interns, which demonstrated worsened empathy scores within the first 5 months of their internship year. A very bleak quote from the article says, "Enthusiasm at the beginning of internships soon gave way to depression, anger, and fatigue." A review article published in 2011, which captured 7 studies describing medical resident empathy, identified a significant downward trend in empathy scores in 6 out of 7 of those studies. And the 7th one, just the difference was non-significant, but no improvements. Providing some positivity, however, was this one descriptive interview-based study that was done with PEDS residents in 2018 out of BC Children's Hospital. They did conclude that there was a self-reported increase in empathy among senior residents in their 3rd and 4th years when compared to more junior residents. This was attributed to increased knowledge about pediatric illnesses. That being said, the study did not use any standardized empathy measures, and they also had a sample size of only 10 residents. So I will say more research is definitely needed in order to understand this different phenomenon that they observed. Let's take it one step further. What about attending physicians? So in one study, the researchers reviewed audio recordings of physicians who were assessing patients with lung cancer at a veterans hospital. 384 empathic opportunities were identified in these recordings, and physicians responded empathically to only 10%. 50% of these empathic responses occurred near the end of the visit, and it was noted that physicians overall provided little emotional support and often shifted to biomedical questions and statements. In another study, which analyzed 398 oncology clinic conversations, 292 empathic opportunities were identified. Physicians responded with continuers, which means phrases which encourage the patient to keep sharing, only 22% of the time. Researchers also reported in this study that the younger oncologists were more likely to use empathic statements than the older or more seasoned oncologists. Now, circling back one last time to that initial study, there is a flicker of hope to be found when you focus in a little bit more on the results. While the majority of participants had declining empathy scores over time, 27% of students actually did not experience erosion of empathy, and their empathy scores remained stable across their 4 years of training. So this leads one to question whether there might be some protective factors which may diffuse these harmful influences. Is it possible that empathy can be nurtured or even potentially taught? And on that note, I will pass the floor over to Sarah to talk about next steps.
Hello, everybody. I apologize in advance if I'm rambling at all. I am post-call right now, but that's okay. But we wanted to explore kind of brainstorming next steps about what do we do next? If we know that this exists, if the literature is pretty clear, both from a language perspective and an empathy perspective, that these are things in our medical system that we still have a lot of progress to make, how can we start to make this progress? And interestingly, I think a lot of the factors that were identified in that Menti poll we just did, a lot of the things you all brought up were exactly the things that are apparent in the literature, but also came to my mind that I wanted to explore a little bit. So first of all, to touch on Alex's point, and so if we're thinking that medical school is potentially where this erosion of empathy starts, then it begs the question of, can we start to intervene at the medical school level and the medical student level? And can we teach empathy? Can we start to incorporate more empathy training at that early stage of medical training so that as these medical students become residents and then ultimately become staff physicians one day, will that carry forward? And so this was a great study published in Academic Medicine back in 2013. So sorry, it was kind of published after the aftermath is maybe a strong word, but after some of the studies Alex talked about came out that really showed this erosion of empathy during medical school. And it's a systematic review that looked at a number of different educational interventions or studies that were looking at educational interventions. And they covered a broad range of things. So they both covered kind of your more classic like medical school teaching and things that, I related to as things I'd been exposed to in my medical school training. So patient interviews, like standardized patient interviews and communication skills training, but also lots of these interventions took a more creative lens to approaching empathy in terms of really incorporating like creative writing and drama and patient narrative and creative arts. And that's something I don't feel like was part of my curriculum. So I thought that was quite interesting. And essentially what this systematic review showed is that yes, these educational interventions can help to cultivate empathy in undergrad medical students. And most of the studies did this by having questionnaires, like empathy-related questionnaires before the intervention, and then directly compared them to the results of these questionnaires following the intervention. And so something that the systematic review pointed out, and so did many of the individual studies, was that, you know, does this necessarily translate into clinical practice? It's wonderful if you can show that an empathy score improves either through, you know, a self-reported questionnaire or other forms of questionnaires, but you know, does that necessarily mean that when that person gets into clinical practice or is around a real patient, that their empathy improves in those scenarios too? And so that's certainly something that needs to continue to be explored. And then what I liked about this systematic review is it also brought up, again, a lot of the things that we've been bringing up is, you know, it's not necessarily just that we're not teaching empathy well enough. Alex, I think, said it best, that most of us go into this profession because we are empathetic people and we want to help and we want to make a difference and we want to care. And so is it all of those other factors that are at play? Whether it's stress, fatigue, the hidden curriculum, you know, needing to detach in order to I think someone said it in the Menti, like a survival benefit, or and so those are important things to think about too, that it's great if we can teach empathy, but if those negative factors still exist once those medical students get into their third year of medical school and then beyond in their careers, then maybe we're not really addressing the root cause of things. And so moving along, I wanted to then talk about how can we address those things. So these were things that when you Google kind of erosion of empathy in medicine or struggling to be empathetic as a healthcare provider, or often what I found was that compassion fatigue and that erosion of empathy, those were terms that tended to be used a little bit interchangeably. And these are things that come up. And I think we've all seen these before, right? At every kind of wellness session or wellness talk, which is, you know, you just be a more well person and, you know, be more mindful and make sure you're regularly exercising and you have a self-care routine, and take breaks. If you feel like your patient load is too much and that's why you're not being empathetic, then take breaks and step away from things and solve your burnout. And I think we all, you know that these things, yes, have a role and yes, are important in wellness, and certainly matter. They're not going to fix everything. And so there's a quote on the next slide, and I think Dr. Langevin in the chat kind of said the same idea. This is from an article, like a narrative article in the AAMC on their website, but essentially it's critical to realize that this epidemic of compassion fatigue is a shared responsibility. Individuals are not going to resilience their way out of this. The medical system and culture of medicine have to change. And so I wanted to focus on those things, that yes, there still has to be a personal responsibility. I think especially as it links into the language part of this presentation, there has to be on our own parts, right, reflecting on the language we use and the notes that we write and the interactions with our patients that we have. So you can't completely step away from that personal responsibility, but recognizing that a lot of the problem and a lot of what contributes to this erosion of empathy is part of the culture of medicine and the system that we exist in. And so if we really want to change it, we have to think about changing the system. And so that led me to brainstorm kind of ways in which we could change. And as I was brainstorming, I came across this 4 steps to empathy on the CMA website. And so I stopped at number 1 because I thought that I mean, it's all it's intuitive, but when you really think about it, and the few factors that I'll talk about on the next few slides, this is often where, you know, we fall short, right, to begin with. And so empathetic communication, the first step is that when you're communicating with somebody else, you need to be able to perceive and identify the emotions that you're seeing. So how is that person feeling in that moment? You know, can I not only recognize how they're feeling, but can I name it? Can I identify it? Can I attach an actual emotion to it? And it's only in doing that then we're able to kind of go down the next steps of empathy. And so interestingly, I think our medical system doesn't always allow us with opportunities to even get to that step. And so the two biggest areas that I thought of, the first one on the next slide that I wanted to start with was talking about kind of the working conditions that we exist in, and what if the working conditions don't allow us to get to this crucial step. So as you can very obviously see by that picture, we're talking about fatigue in medicine, and that was something many of you said in the Menti poll. I think fatigue in medicine, I mean, anecdotally, we all know what that feels like, whether it's with our patients or even, interpersonal conversations with our colleagues, or even with people outside of medicine, like with our loved ones when we get home in the morning, when we're tired. You know that you're not, like, I don't feel as empathetic. You know that it's hard to care as much. It's hard to be as compassionate, that you're a little bit more easily frustrated or easily irritated, or get defensive more easily. And so we know all of those things, but I wanted to take that one step further and kind of look at what the literature said in terms of identifying emotions and how sleep deprivation actually negatively impacts our ability to do that. So this was a review article in Nature, in Nature Reviews Neuroscience, that I thought was quite interesting. I'm in no way a neuroscientist, so the intricacies of some of the fMRI findings I won't claim to fully understand. But essentially, this review article talked about a number of different studies that have shown the difference between our brain activity in sleep rested and sleep deprived states, and how that translates to our ability to identify emotions. So in this second row, like the B part of this diagram, essentially they were looking for, when they showed individuals a range of different emotional reactions that ranged from very negative emotion faces to more neutral faces to positive. When you're sleep rested, you're really able to discriminate between the neutral and the negative and positive emotions quite accurately. But you can see with the curve with the sleep deprived side of things is that you tend to almost overgeneralize emotions quite a bit more, which I thought was interesting, is perceiving a neutral emotion to be more negative or to be conversely more positive. I think probably where we get in, I mean, either way, I think could be problematic, but probably where we get into more trouble is that perceiving it to be negative. And again, subjectively, I think we can all relate to this, where 3 a.m. things seem like the end of the world, and then you get a good sleep and wake up, and it's not actually that negative after all. And what you were maybe perceiving, whether it was a conversation with somebody or an encounter with somebody, was actually a lot more neutral than it felt at the time. And so I definitely think we see this playing out in clinical practice. And then C below, which I thought was interesting, was again, this was a study where they were looking at in a sleep rested state and a sleep deprived state is when they were shown facial expressions displaying emotion. Number one, could the individual identify it? And then were they able to mimic it appropriately? And this is obviously an oversimplification of it, but they found that in the sleep deprived state, we're not as good at mimicking those emotions. And so if we're not as good at being able to, number one, pick up on those emotions in other people and then express them ourselves, then I'm not sure how we're supposed to be empathetic when it's the middle of the night and we haven't slept. And so I think that's a huge part. And this has been described in lots of other studies. The second one on the next page, the reason I wanted to bring this one up was just because a lot of the studies that I read looked at sleep deprivation in terms of, oh, for the past week, you've only gotten 5 hours of sleep a night instead of, the recommended 8. But this study actually sleep deprived the individuals for a full 30 hours, which for many of us residents, that's the reality of our lives, unfortunately. And so similarly to the other study, they showed kind of this range of emotions, and they had happy, sad, angry, like kind of all your big emotional categories, and showed a slow progression from a neutral face to like the full extent of that emotion. And they asked individuals in the sleep control group and then the sleep deprivation group to essentially, when they were shown a face with an emotion, to rank on a scale of 1 to 4, like neutral all the way to that full expression of that emotion, what they thought of it. And they weren't able to ascertain, like they weren't able to accurately do it in a sleep deprived state, and actually was a bit opposite to the study on the previous page where they weren't actually overgeneralizing neutral faces as being more emotional. They were doing the opposite, where they were ranking lots of things as neutral. So they weren't picking up that these individuals were showing subtle signs of being angry or being frustrated or being sad or being upset. And so, you know, I think we can extrapolate this to our patient encounters, where in a sleep deprived state, if we're with a patient and we're not able to pick up on the body language that they're giving, or their facial expressions, or the ways in which they're showing us that they're struggling in that particular encounter, then how can we be empathetic towards them? And interestingly, the study, they then let those sleep deprived people sleep on the second night, and they showed a recovery in this ability. And so I think that is a little bit hopeful that that if we do catch up on our sleep, that we regain that ability to discriminate emotions, and hopefully to be more empathetic. So that's the sleep piece. And then the other piece that all of you brought up quite accurately as well, and things that I thought about, is the time piece. We know that healthcare for all healthcare providers is becoming, you know, more and more busy, that there's increasing patient complexity, increasing patient acuity, and it leaves us with less time constantly. And so on the next slide, it talks about this New York Times article that was actually a very interesting read, if anyone would like to read it. It's called Taking Time for Empathy. But again, they pointed out, I think, the obvious of what lots of us are thinking, is that lots of us feel like there's not enough time for empathetic responses. And so below, when I looked into the research of, you know, how much time are we actually spending on direct patient care? And I don't think it's surprising, the results, but studies have found that in outpatient settings tends to be about 27% of time that's spent on direct clinical care. The rest of the time is spent doing other things. The most whopping of that, the 49%, is on the EMR. So documentation, checking inboxes, following up results, all of those things, which is still providing patient care. And it's not to say that the things that happen behind the scenes are not important, but when it comes to empathy, that's maybe where we're struggling a little bit. And inpatient, I think no surprise to any of us, was the same, where 66% of the time we're doing indirect patient care, most of which is documentation or keeping medical records or looking through medical records. And so while lots of these tasks are necessary to provide patient care, I think when it comes to empathy, number one, I don't think we're able to become empathetic if we're not spending time with our patients. I think I feel a lot more empathetic when I'm listening to a story from a patient or their family themselves than if I'm just reading the admission note in the chart. But then second of all, and what matters most, is that our patients aren't going to feel our empathy if we're not spending time with them. Even if maybe we're being empathetic behind the scenes, that's not necessarily what they see or what matters most to them. This New York Times article, as an aside, it did talk about kind of some positive things, and how there are studies out there that show that even in time constraints, it focused mostly on clinic settings, but even in very busy clinics, that patients, even small opportunities for empathy are really highly reported by patients. And even those small opportunities where we miss times where we can show empathy, patients notice that and bring it up. So there is hope that even in our very busy schedules, that on a personal level, we can try to interject some amounts of empathy. But I think, you know, the overarching system barrier still remains, that if we're not spending enough time with patients, it's really hard to be empathetic. And so on the next slide, this was me brainstorming things that we can do next. Obviously, this is an oversimplification of things, that one slide does not fix the complexities of our medical system or our medical culture. But these are things that, thinking about those two factors and those two results from the literature, of maybe things that we can start to move towards as a system. So sleep deprivation, I mean, there's lots of evidence out there of all of the ways in which sleep deprivation is bad in medicine. I think the empathy piece is only just one of them. We all know the results or the studies that show, you know, the level of mistakes that get made, and the impacts on the like personal well-being of that individual who is sleep deprived as well. And so from a residency perspective, and for others later in their careers who still do 24-hour call models, anyone who knows me knows that I'm a very big proponent of not doing 24-hour call, that I think it's quite inhumane. And I think the literature shown here is just some of the ways in which that it's not beneficial for ourselves or for our patients, but definitely to move towards night float models, to think about the number of nights worked per month and whether that's sustainable in residency. And again, that's what myself and my colleagues can speak to better, because that's where we're at with our training, but we can work up to 7 nights per month, including then lots of daytime hours as well. And maybe that's too much, and maybe that sleep deprivation is not the way we should be progressing our system. And then fortunately in a pediatrics residency, I would say our post-call days are always protected, and there's never a question about whether we should be staying or going home. But I know from lots of my medical school friends and colleagues that that is not the case in all programs. And so again, recognizing lots of these things are focused most on the residency lens because that's where I'm at in training, but I think we can all brainstorm ways in which in all of your careers that maybe the system needs to change to better support or better reduce sleep deprivation. Providing more patient care, direct patient care. Again, obviously this is a complex system, and the volumes of patients and the way in which, our hospital, for example, that we're seeing more and more patients and more complex patients. So it's not a simple fix, but these are kind of some smaller, simpler fixes when I was thinking about, the amount of time that we spend on documentation. So lots of us love to refer to Epic and all of the notes as note bloat, in terms of, there's just miles and miles of notes written in a patient chart that many of it is copy and pasted from previous notes, and it's not necessarily new information. And so can we eliminate lots of that and eliminate the time we're spending on documentation if it's not actually benefiting patient care? And then I also think things like what Alberta is doing, moving towards a universal provincial EMR and getting everybody on board with Epic. I think that could be really interesting, because I was thinking about, in the inpatient world, how many minutes and hours we spend, trying to track down results, and let's get the medical student to call Gatineau to find the results of those blood cultures, and trying to figure out, what had been done at a peripheral center for a patient. And if we had all of that access at our fingertips, would that simplify things, and would that free up more time to interact with our patients? And then I think it'll be interesting to see, where technology goes, and with AI technology in particular. And I'm in no means a super tech savvy person, but I know, already they're starting to come out with different AI models that will listen to your patient encounter and then will write your note for you. And so whether in the future we can start to incorporate some of these things, again, to alleviate some of the administrative tasks that we may have as healthcare professionals, and move towards having more time to spend with our patients. And then lastly, I still think, despite all of these things, it is important to have empathy education in curriculums, whether it's those interventions that those studies looked into, or even things like this, I think are very important. Because with the language piece too, that if we're not talking about it, we're not necessarily aware that we're doing it and aware that it exists. And so whether it's at the medical student level or residency or a continuing medical education level, to continue to have these conversations and to brainstorm ways in which we can be better as healthcare providers. And that's the end. Those were our thoughts about, again, a pretty complex subject, but hopefully this sparked some reflection in everybody and made you think about your own practice and your own systems that you work in. And we would love to open it up to comments or questions and pick all of your brains.
Thanks. That was a very well organized and communicated rounds, and you timed it perfectly. So congratulations. That's hard to do with 4 people on a complex topic. So I do see a few people who have come on camera, and I assume we'll have some good questions and comments and reflections probably as well. Sam just used the word reflection in her chat as well. So I'll open it up. Toby, I saw you come off camera first. Do you want to? Oh, Anna put her hand up.
I'm okay to defer to Toby. Well, since you called me out, I'll go ahead. So just curious, I love the talk and all the, great thoughts, great reflections, in particular, really interesting evidence you've presented. When you are looking and doing your research, and or maybe even reflecting yourselves on your own residency training, any protective factors or specific experiences that were identified as sort of like empathy generating one? So I recognize protective factors being, getting enough sleep, but beyond that, in terms of like our curriculum, was there anything that came across, for example, for the BC Children's Study, which I'm not familiar with, where they had the increase, or just for yourselves in your own training, things that might be somewhat sort of I don't know if antidote is the right word, but things that are helpful in terms of helping our learners stay grounded within that sense of empathy. Any thoughts?
Yeah, I can start with my thoughts, not so much literature based, but when I was reflecting on my own, like you said, my own residency, I think Alex mentioned the role modeling from kind of the negative perspective, but I also think that's a huge protective factor. And I think when I'm working with any healthcare professional, like whether it's our allied health or the staff physician I'm with, or other residents I'm with, or even learning from juniors sometimes and from our medical students who are showing empathy and are showing positive interactions and are even in busy schedules are taking time to sit at patients' bedside and get to know them and talk to them. And I think those are the things that stand out for me as when I can see the attributes that I'd like to have as a physician in my future career when I see them exemplified in the people I'm working with. And so again, I know that maybe falls on a little bit more of the personal lens of just people being more empathetic, but I think that's huge, is just seeing people trying to rewrite the culture themselves.
I think another thing that Dr. Major, I think, brought up in one of our teaching sessions a few months ago was, and this was in the context of complex care patients, but I think it could apply to any patient, was to ask the parents to see a photograph of the child when they're well. Because I think so often we just think of a child as, oh, it's this condition, they're in bed, they're sick, and we don't think of all the other aspects of their life, especially with our complex care patients. But being able to see a photograph of the child when they're well and they're happy and seeing all the other things that they do in their life, I think just makes the patient more real to you. So ever since she mentioned that in our talk, is something that I've done with a lot of parents, is ask them to see a photo of the child when they're well. And I find that that's another way of like really holding on to that empathy.
And just to answer Dr. Odson, your question kind of directly about the BC Children's Study, it was, like I said, descriptive and it was interview-based. They didn't have a lot. It was self-reported by their residents that responded that they thought perhaps that their empathy increased because their knowledge increased. I don't know if I really think that increasing knowledge is the way to increase empathy, or if that's really the answer. I think it's more focused on the humanistic parts of medicine that will do it.
I would love to pirate some of your amazing slides on how to write a really nice note for our onboarding. So I'll connect with you offline about that, because I think you did a really nice talk, and some of those exemplars of just, as you say, the choice of language is a great place to start. So thanks so much. I'll pass it to Anna.
Thanks, Toby, and thanks to all of you guys. It was an amazing talk. I'm going to reflect that one of the most, probably the most impactful changes in my approach to all of this has actually been the ability to work, and the privilege of working with a patient partner closely. And I wonder if you came across any literature that supports sort of how working with patient partners can actually address some of these issues around our use of language and our empathy.
That's a really good question. It's not something that I really came across specifically in the erosion of empathy section of my review. I will say, kind of just incidentally, I guess, spoiler for next year's, my presentation at Sage Rounds next year, but one of my research is related to patient education, and teaching patients about their diagnoses and diseases and things like that. And something that I came across in my study was that education leaders, both UGME and PGME, strongly thought that using patient partners benefited patient education curricula. So I do think there's a link there.
And so interesting that the CPD world is actually getting on the bandwagon, I think, of using patient partners far quicker than either the PG world or the UG world. So hopefully over the next few years, that'll change.
Thanks. Melissa.
I have a question, but just what is a patient partner? Before I ask my question, is it
So and I'm going to call myself out a little bit. My language, I said using a patient partner, working with a patient partner. So at the AFMC, we have a lead patient partner who brings the patient voice as sort of a central part of all of our education endeavors. And it's been extraordinarily valuable because she happens to be very comfortable. She has she has extensive medical training and has been able to call out some of the use of language and really lead a lot of us to self-reflect in how we structure things, with the perspective that really everything that we do is for our patients. So having them at the center of all our education initiatives and other things that we put together is a really neat way of bringing that voice in and giving us that perspective that we may actually not always see.
Yeah, thanks, Anna. And I think I'll just add maybe to that a little bit. You know, patient partner can be a bit of an umbrella term, and then you can have specific roles within. So if I think of the patient-oriented research projects that I'm involved in, we have both patient researchers who are involved in developing and forming the research question and analyzing the data, but also patient advisors who are really there to advise on the methods and the implementation of the project, but they're both patient partners, right? So different ways of including the patient voice and work.
Yeah, and just adding that some of our most powerful and well-perceived lectures are when, you know, physicians bring in their patients and their families to speak to it. So I think that's a great idea.
Thanks. I just wanted to put in a plug for the AI world. You know, it's been like a disruptor for good and for interesting conversations in the last 18 months. But I know that Epic has an AI function, and I understand that it might be coming to us, but probably not till 2025. I think that, you know, and this is a leadership, this beholds to people who are in leadership positions to give, because part of empathy is related to time. And sometimes the ability to sit, you know, you were saying what proportion of your encounter is related to patient care versus the documentation and all of the other steps that we do. And so that part about if you open up the time and you give that gift of time back, then you can spend the time that you're otherwise clicking through to have the encounters. And so I think that it might be an interesting thing for us to, and for speaking, I was just at a conference where people are using AI more and more, like in general pediatrics offices, and within 2 weeks, just their absolute sheer joy of reconnecting with medicine because of like how amazing the AI can be in like listening to your encounter and helping with the paperwork portion of what we do. So just wanted to put that plug in of holding the system accountable for allowing what is naturally there to continue to exist, because I think you've highlighted the fact that people who come into medicine actually are more empathetic and are more resilient than the general population. So we need to find ways of sustaining that, and if it looks like AI isn't coming to us until 2025, maybe we need to push for that to come earlier.
Okay, I think with that, we'll call the rounds. We're at 9:29. I had a couple of questions I was thinking of, but they'd be about 20-minute discussions. So I think, you know, this is an excellent topic, and, you know, I think more discussion should be had, both formally and informally. Yeah, thank you again. Excellent rounds. And really appreciate the effort that went into that.
Thanks, everybody. And Pranish, we can have coffee at another time then.
Sounds good, Jess. All right.
Thanks, everyone.
Thank you.
Bye.